the next 15 minutes or so, we will briefly introduce this topic called sudden cardiac death, which is the devastating culmination of a variety of cardiac conditions like, for example, post-MI LV dysfunction, dilated cardiomyopathy, Brugada syndrome, long QT syndrome, so on and so forth. So it is a devastating end to some of these cardiology conditions. So it's very important to assess the risk, who is at risk for cardiac death, and manage them accordingly. It's very important to assess the risk because if you overdo assessment of sudden cardiac death, for example, you may indiscriminately implant defibrillators for patients who are at low risk for cardiac death. So you should not do that. You should correctly identify the risk, identify the suitable patient who is at high risk for sudden cardiac death and manage accordingly. That's very, very important. So we'll define what is sudden cardiac death. We will list the arrhythmias which are responsible for sudden cardiac death. What are the underlying disease entities which contribute to arrhythmias which cause sudden cardiac death? What is the role of implantable cardioverter defibrillator for prevention of sudden cardiac death? In prevention, we have primary prevention and secondary prevention. Primary prevention means somebody who has not had an event but who is at high risk for such an event, you implant an ICD, that's called primary prevention. Somebody who has already survived hemodynamically unstable ventricular tachycardia or who has survived cardiac arrest itself, then you put an ICD, it is called secondary prevention. It's very, very easy that somebody who has already survived a cardiac arrest becomes a definite candidate for an ICD implantation. It's bad for the patient, but it is good for the treating physician because the decision making is very easy. Somebody who has already had a cardiac arrest. The problem becomes more difficult to identify those candidates who are indicated for primary prevention ICD. That is very, very important. And I'll spend some extra time on how to risk stratify those patients for primary prevention. Indications for ICD implantation, how do you risk stratify for primary prevention? And previously we used to call anybody with a dilated left ventricle, ejection fraction 35%, and some mild degree of mitral regurgitation. You do a coronary angiography, the angiography is normal. We used to give the label as non-ischemic or idiopathic dilated cardiomyopathy. But now there has been a sea change in what is called idiopathic dilated cardiomyopathy. The LV need not be dilated. There can be some regional wall motion abnormality, but the LV ejection fraction can even be 50%. That is the importance of recognizing a new entity called hypokinetic non-dilated left ventricle. Meaning LV is not dilated, it is not severely impaired, there is some hypokinesia in some territory alone. That is also very important to identify when it comes to risk stratifying for sudden cardiac death. And we'll have some illustrative case examples to highlight some crucial learning points as we go along. So patient number 1, 60-year-old male, multiple risk factors, old anterior wall myocardial infarction about 20 years ago. He presented not now, long back, with severe LV dysfunction, ejection fraction 30%. He presented to a nearby hospital with rapid palpitations, hemodynamically unstable. He had monomorphic ventricular tachycardia on presentation with hypotension. He underwent a successful DC cardioversion, and this is the ECG. You see a rapid monomorphic ventricular tachycardia as a consequence of old myocardial infarction scar with severe LV dysfunction. So this patient has already had an event. So if you recommend an ICD for this patient, it's called secondary prevention. And this is the ECG after termination. You can see a QS pattern all the way to V6. So old anterior MI, and that is the left ventricular function, severely impaired left ventricular function. And this is the angiogram. It was an occluded left anterior descending artery. The LAD territory was non-viable, so there is no merit in doing a revascularization for the LAD. This patient becomes a class 1 candidate for an ICD implantation. So here the decision making is rather straightforward. Old MI, LV dysfunction, ejection fraction 30%, already sustained a monomorphic ventricular tachycardia. So there is no confusion here. This patient becomes a clear-cut candidate for an implantable defibrillator implantation. So here there is no difficulty. So that was a prototype case example for secondary prevention defibrillator implantation. Defibrillator is a device little larger than the pacemaker, which is implanted through the subclavian vein, and the lead is positioned in the right ventricle. This is the X-ray of a patient with a single chamber defibrillator. Sudden cardiac death is natural death from cardiac causes heralded by abrupt loss of consciousness within 1 year of onset of an acute change in the cardiovascular status. And these are the time references in sudden cardiac death. Prodrome, new or worsening cardiovascular symptoms in a patient who was otherwise reasonably stable. Onset of terminal event, there is an abrupt change in clinical status which can be arrhythmia, it can be fall in the blood pressure, it can be chest pain, dyspnea, lightheadedness. And of course the patient evolves into what is called cardiac arrest, where there is a sudden collapse. And if resuscitated successfully, you call it resuscitated sudden cardiac death. Sometimes you may fail to resuscitate also. So these are the 4 temporal perspectives of sudden cardiac death. And this happens over this particular time frame. What are the underlying arrhythmias which cause sudden cardiac death? 80% of the arrhythmias is either due to ventricular tachycardia or ventricular fibrillation or polymorphic ventricular tachycardia. 80% due to ventricular arrhythmias and only about 20% due to bradyarrhythmic problems. This is one of the monitoring which shows a patient is in sinus rhythm, develops ventricular tachycardia which degenerates into ventricular fibrillation, and over a course of about 10 minutes this patient was being monitored, something like a Holter monitor or an implantable defibrillator. You see a flat line. So this is exactly what happens in an unresuscitated sudden cardiac arrest, which happens oftentimes out of hospital. So what are the causes and contributing factors for sudden cardiac death? 1, coronary artery anomalies, myocardial hypertrophy like hypertrophic cardiomyopathy, myocardial diseases like myocarditis, sarcoidosis, inflammatory conditions, degenerative conditions, neoplastic conditions, valvular heart disease, congenital heart disease, channelopathies like Brugada syndrome, so on and so forth. All this can culminate in sudden cardiac death, of which coronary artery anomalies and related myocardial infarction, LV dysfunction and dilated cardiomyopathy forms the major contributor to sudden cardiac death. What are the underlying causes of fatal arrhythmia? Coronary artery disease contributes to 80%. And it is one of the most important contributors to death. This is an American data. It is much more than any malignancy, road traffic accident, strokes and so forth. It's important to understand that the high-risk population that we have been talking about, old MI, LV dysfunction, sarcoidosis, hypertrophic cardiomyopathy, Brugada syndrome, where we normally implant an ICD, is only a tip of the iceberg. It's only about 10% or less of the general population. Whereas the general population without any of these entities contributes to the maximum sudden cardiac death events, for example, a first myocardial infarction. So prevention has a very important role. Modifiable risk factors play a very long role than implanting ICDs for patients when you address the general population as a whole. How do you prevent sudden cardiac arrest? Drugs, devices and adjuvant treatment options, about which Dr. Shanmugasundaram has already alluded to during his presentation. These are the drugs which are useful. Devices can be pacemakers, defibrillators, etc. And adjuvant treatment options, again he discussed about radiofrequency ablation, stellate ganglionectomy, so on and so forth. We will concentrate a little bit on devices in the context of sudden cardiac death. ICD, implantable cardioverter defibrillator, is a sheet anchor in the treatment of, or rather prevention of sudden cardiac arrest in high-risk population. How does it work? It constantly monitors the heart rate, the rhythm, and it identifies promptly sustained VT and VF episodes and delivers accordingly therapy. This is an example of a ventricular tachycardia detected by the device, and anti-tachycardia pacing has been delivered and sinus rhythm has been restored. So overdrive pacing itself can be done by the ICD, which can terminate a ventricular arrhythmia. Of course, if overdrive termination does not terminate, it will give a shock. Akin to the shock that we give in the intensive care unit, the device delivers a shock. It's called cardioversion. And if it is ventricular fibrillation, it defibrillates again by delivering an appropriate shock. So that's how an ICD works. Indications for ICD, as we have already discussed, it can be secondary prevention, like the case example that we just discussed. Old MI, severe LV dysfunction, documented ventricular tachycardia, clear-cut case of secondary prevention ICD. And of course, the next is, why should you wait for the first episode of cardiac arrest? Even before the first cardiac arrest happens, if the patient is at very high risk for developing a cardiac arrest, you can implant an ICD even ahead of the first event. Why wait for the first event which could prove fatal? That's primary prevention. What are the common clinical conditions where an ICD may be indicated? Chronic coronary artery disease, old MI, scar-related LV dysfunction, dilated cardiomyopathy. I already spoke about an entity called hypokinetic non-dilated cardiomyopathy, which is becoming increasingly recognized as a cause for heart attack, so cardiac arrest. So don't be happy that the ejection fraction is 40%. I will show you a case where we learned the lesson in a very bitter fashion, where we went by the LV dysfunction and we had an accident. So dilated cardiomyopathy, hypokinetic non-dilated cardiomyopathy is also an entity that you should be wary of. Hypertrophic cardiomyopathy in the presence of risk factors, arrhythmogenic right ventricular cardiomyopathy, Brugada syndrome, cardiac sarcoidosis, long QT, so on and so forth. These are some of the common clinical entities where an ICD may be indicated if the patient is at a high risk of developing cardiac arrest. We have now documented risk factors which you can assess in each of these conditions to say this patient is hypertrophic cardiomyopathy but low risk for sudden cardiac death. We can treat them with beta blockers. Here is another patient of hypertrophic cardiomyopathy. There are a host of other risk factors, high risk for sudden cardiac arrest, so you should put an ICD. So we'll come to that in a little while from now. Whatever be the underlying clinical condition that we just discussed, all these conditions, if the patient has already survived a cardiac arrest or had a documented unstable VT, in the absence of reversible causes like electrolyte abnormality, ischemia, drugs which are causing arrhythmogenic drugs, etc. In the absence of all that, if somebody has already had a cardiac arrest, becomes a candidate for ICD for secondary prevention, bad for the patient, but easy decision for the treating physician. We can make a decision easy. So there is no confusion here, not a good news for the patient. Next, no previous episodes. Here comes the problem. Somebody has hypertrophic cardiomyopathy. Somebody has dilated cardiomyopathy. Never had a cardiac arrest. No previous episodes. Only in pre-specified high-risk population as indicated by additional risk markers. We'll come to that shortly. In the presence of additional risk markers, you know that this patient is at a high risk for cardiac arrest. So that patient becomes a candidate for primary prevention. Here the job becomes difficult for the treating physician because you have to employ all these risk criteria. You have to convince the patient and implant a defibrillator for primary prevention. And if you don't do in a patient who deserves, it can be a problem for litigation in future. Not always an easy decision for the treating physician. You have to employ all your experience, stick to guidelines and understanding to recommend an appropriate device for primary prevention. In the process, you should not recommend indiscriminately defibrillators for those patients who are not at high risk. That's very important. So ICD for primary prevention. In LV dysfunction due to old myocardial infarction, ejection fraction less than 35% is an indication for ICD. So old MI, severe LV dysfunction is an indication for ICD. In hypertrophic cardiomyopathy, if somebody has family history of sudden cardiac death, massive left ventricular hypertrophy, more than 3 centimeters thickness of the septum, unexplained syncope, apical aneurysm of the left ventricle, borderline impairment of ejection fraction to less than 50%. HCM usually has a hypercontractile ventricle. If the EF is 50%, it becomes a reasonable candidate for ICD implantation. Or if there is non-sustained ventricular tachycardia or extensive late gadolinium enhancement in cardiac MRI. Another important thing I want to stress is the importance of cardiac MRI as an important investigative tool to identify those patients at risk for sudden cardiac death. You should have the lowest threshold to recommend cardiac MRI. We'll come to that in the next few minutes. So ICD for prevention. We'll spend a little time here. ICD for primary prevention in idiopathic dilated cardiomyopathy. As I already told you, do not stick to the ejection fraction of less than 35%. You can have an entity called hypokinesia with not so dilated left ventricle. So you have to move beyond LV ejection fraction. There is an entity called non-dilated left ventricular cardiomyopathy or hypokinetic non-dilated LV cardiomyopathy, and the emerging importance of multimodality imaging, particularly cardiac MRI and genetic study for pathogenic mutations. That's very, very important as risk modifying tools in this particular entity. Previously, we used to wait for the ejection fraction to come less than 35% to recommend ICD in patients with dilated cardiomyopathy. You do not have to do that. Ejection fraction may not be very low. There may be some hypokinesia. Subject them to cardiac MRI. Look for the pattern of late gadolinium enhancement, which is a very important risk modifier. And also genetic study is also very important because certain mutations confer very high risk for cardiac arrest in patients with so-called dilated cardiomyopathy or not so dilated cardiomyopathy. Previously in the year 2013, it was a class 1A recommendation for dilated cardiomyopathy if the ejection fraction is less than 35%. The European guidelines also was a class 1 indication. Now we have moved on from this ejection fraction to more severe, more stringent risk assessment of all these patients. Now it's a class 1 recommendation to consider contrast enhanced cardiac magnetic resonance imaging in patients with cardiomyopathy at initial presentation. Send them for cardiac MRI. Do not wait for the ejection fraction to come to less than 35%. This is a changing paradigm in the workflow of patients with so-called cardiomyopathy. You go by the clinical presentation, go by the cardiac morphology by echocardiography, not just ejection fraction, cardiac MRI. Look more carefully at the ECG, low voltage complexes, fragmented QRS complexes, very wide QRS complex, unexplained sinus tachycardia. These are all subtle signs in the ECG which tell you that you are dealing with a high-risk patient. And of course, certain genetic mutations also confer very high risk. So if you look at the current guideline for dilated cardiomyopathy or non-dilated LV cardiomyopathy, if the patient already had an event, it's very easy. Secondary prevention, class 1 indication. Or if there are other factors like syncope, significant LGE on cardiac MRI, fragmented QRS, low voltage QRS complexes, wide QRS more than 150, family history of sudden cardiac death, and of course inducible ventricular tachycardia and EP testing. All this has come into the gamut of risk stratifying markers when you deal with patients with not so dilated cardiomyopathy. And these are some of the mutations. In the interest of time, I will not go into the details. At least remember, if there are postgraduates here, there is something called lamin AC mutation, transmembrane protein, phospholamban. All this confers a higher risk for sudden cardiac death, even in the presence of not so compromised ejection fraction with normal coronary arteries. I'll stop with this case example where we learned this lesson very bitterly. A case example to highlight the challenges in decision making when it comes to primary prevention in patients with assumed dilated cardiomyopathy. A 47-year-old lady, no comorbidities, had some vague sensation in the head, walked, hit the door and sat on the floor, had some sweating, probable transient loss of consciousness because there was no witness, involuntary micturition, recovered in a few minutes, had some fatigue post-recovery, no reliable witness, no prior history, no family history, was initially evaluated in neurology and everything was normal. She had frequent ventricular ectopics and so was referred to cardiology. Clinical examination was unremarkable and this was the ECG. You see some ectopics. The ectopics have an LBB right axis morphology which we say is the right ventricular outflow tract VPC. There was no QRS fragmentation. The QRS voltages were okay, except that there was some delayed R wave progression all the way to V5. Delayed R wave progression. Echocardiogram was mild LV dysfunction, about 47%. By Simpson's, it was 47% ejection fraction. So going by the conventional criteria, this patient is not a candidate for implantable defibrillator. Exercise stress test was negative for ischemia, a screening tool for coronary artery disease. In recovery phase, there were some isolated ventricular ectopics. We did a 24-hour Holter monitoring. There were again isolated ventricular ectopics. 1 or 2 runs of 4 beats of non-sustained ventricular tachycardia was the only abnormality. 2 runs of 4 beats of NSPT. And the VPC burden was only about 2.9%, 2 runs of NSPT of 4 beats. Cardiac PET MRI was done to rule out arrhythmogenic RV cardiomyopathy, granulomatous cardiomyopathy, to assess for LGE pattern, etc. The cardiac MRI was normal. There was no, the ejection fraction was reported as 52% with global hypokinesia, and T1 and T2 matching scores were normal. And there was no LGE both in short axis and long axis, 4 chamber view. No abnormal enhancement. And PET scan did not show any hot FDG avidity anywhere in the myocardium. So there was no active inflammatory pathology also. So in summary, we have a middle-aged lady with 1 episode of arrhythmogenic syncope, no significant LV dilatation, mild LV dysfunction, left axis deviation, some intraventricular conduction defect and delayed R wave progression and ventricular ectopics. Holter monitoring showed only 2% VPC burden, which we often say it's a very, very small burden, and 2 runs of 4 beats of NSVT. TMT was negative, PET MRI was normal study. She was given some drugs like beta blocker, valsartan. She was an asthmatic. She was counseled for a coronary angiogram and EP testing for VT induction protocol. She was not willing for that. And this was the last ECG that I saw of her. There are some isolated VPCs, poor R-wave progression, and interestingly, after every ventricular ectopic beat, the QRS, the morphology was different. Very interesting to know that the axis shifts after, I don't know the relevance of this. So was totally asymptomatic, no occurrence of transient loss of consciousness, no palpitations, repeat echo 1 year later, ejection fraction was 50%. Few weeks after the last follow-up, she was found dead in sleep. So we did everything possible to risk stratify this patient according to guidelines, except that we did not do an EP study for VT induction, but see the accident that we had in this patient. Autopsy was unremarkable. Our younger sister had an ECG which showed the similar left axis deviation. Her echo was normal. We did a genetic analysis in this patient. There were no incriminating mutations in the sister. Younger brother is a software engineer in the US. Again, he was fully evaluated, including a PET MRI and genetic study, and told to be okay. So this case highlights the potential diagnostic challenges in risk stratification in so-called idiopathic cardiomyopathy, in this case non-dilated left ventricle. It also underlines the importance of factors beyond LV ejection fraction, which was not long ago the only criterion for deciding on the need for ICD therapy, and also exposes the limitations of available clinical tools and judgments in a given case. So I'll conclude by saying that SCD is a devastating terminal event with significant socio-economic consequences. With increasing incidence of coronary artery disease, sudden cardiac death is a leading killer globally, far more than any cancer. Though options like ICD are of immense proven benefit to the high-risk patient population, addressing risk factors in the community, for example, control of diabetes, control of hypertension, cessation of smoking, etc., is even more relevant in a country with a lot of constraints, financial constraints like India. Identification of potentially high-risk patient subsets is a major clinical responsibility, like was highlighted in that particular case example. Search for high-risk markers like cardiac MRI, genetic study is even more relevant in a cost-conscious society like ours. Risk stratification tools, cardiac MRI in particular, and genetic testing in selected cases are very useful in patients with idiopathic dilated cardiomyopathy. Of course, not to ignore factors like public access defibrillation and public education on how to use AEDs are also equally important. You can reduce out-of-hospital cardiac arrest to a large extent. Thank you for your kind attention.
Thank you very much, Dr. Natarajan, for your extensive and elaborate talk on the ICD. Any questions from the audience? What is the cost of this ICD now?
The cheapest single chamber defibrillator comes to around 3.5 lakhs. And it works for 10 years.
What is the percentage of pros? Okay. What is the percentage of patients, your patients, you are convinced to accept ICD in the primary prevention?
As already known, the most important constraining factor is the cost. No patient says, I don't like to have an ICD. Oftentimes the problem is the patient knows the benefit of an ICD but cannot afford the cost of an ICD. That is a limiting factor. But as Dr. Madhavan said, you know, have government schemes and all which fund, and public education also is an important role. And all patients who are having ICD should be told that the ICD does not improve the LV function. Recently, one patient sent a legal notice to me. Ejection fraction 30%, dilated cardiomyopathy, already had a ventricular tachycardia, and we recommended ICD and we put an ICD. The ejection fraction continued to be 30% and the patient succumbed after 2 years. So the patients, they served me a legal notice saying that the LV function did not improve. So that is also something we should educate these patients. So I am in a corporate hospital, so patients who come to me are more or less affordable. So if I recommend ICD for about 10 patients, particularly for secondary prevention, 8 out of the 10 will agree for it. Primary prevention, there is a small hesitation on the part of the patient. I would say about 3 to 5 patients out of 10 may agree for an ICD for patient-specific factors. It may not even be the cost.
Post-MI cases? Post-MI cases, how many percentage you are going for ICD?
You are talking about primary prevention, I suppose. Somebody who has not had an event, ejection fraction continues to be 30%. Previously, when we started our program in the year 1998, If you take 10 cases, 9 will be for secondary prevention, 1 will be for primary prevention. That equation over a period of time has changed substantially. We were just looking at the data for one of our physician assistants. We went through the data. In the last 10 years, it's about 6 primary prevention and 4 secondary prevention. So more and more patients have primary. In the US, the predominant indication is primary prevention.
Your place is 60% as primary prevention.
At least 50-50. At least 50.
So EF 35 up post MI.
Post MI, EF less than 35%, large scar.
When would you put a dual chamber ICD?
That's an important question. Whenever there is a bradycardia indication, let's say a patient who needs an ICD also has sinus bradycardia, where the patient is likely to get paced, that is the time you should consider a dual chamber ICD. When it came initially, it was said that atrial fibrillation and things like that can be better discriminated by an atrial lead. So now we know that a dual chamber ICD is largely enough for discrimination problems. So to answer your question in short, when somebody is likely to need pacing, you should put a dual chamber ICD. And the risk of atrial arrhythmias is very high, known atrial fibrillation, etc. You can, paroxysmal atrial fibrillation, you can put.
Thank you.